Those who are on Zoom, I have your record of joining us, so you don't need to do that. So as mentioned, CME credit is provided for this presentation. I'm just gonna go through this briefly here for those who have attended this tutorial review. You'll need to text this code that you see here on the screen. It's also on your sheet there, but this is the code you'll need to text to the 1-800 or the 1844 number that you see listed. Make sure that you do that before midnight tonight if you are claiming credits. But if you have any questions, I'll be here afterwards, so please feel free to reach out to me or in the text, in the Zoom, the chat, please feel free to find me there as well. So those who haven't yet, if you have not registered for CME, find me during the meeting. Otherwise, you can register by sending your email address to the CME office actually. So I would probably find me at the end of the evening or email me. I can give you my information in the chat box and after the meeting. If you are claiming credits, please make sure that you do check your CME transcript frequently to make sure that those credits are showing up on your transcript. You can do that by going to the CME office website. The address is listed there, but of course, any questions, you can reach out to me. Those transcripts are actually used also for those who are AAPP members. You can claim credits through there. So keep that in mind. Their information is listed, but as always, reach out to me. We do want to make sure that we do mention that it is our goal during these grant out presentations to meet these nationally established position core competencies that you see here. And we do need to mention that Dr. Bazaldua has no financial relationship with an eligible company to disclose. So Dr. Bazaldua is going to present to us today. Her topic is an update on evidence-based therapies in primary care. Dr. Bazaldua is a pharmacy faculty for the Department of Family and Medicine. She's also the director of departmental pharmacy education and the director of pharmacotherapy clinic. I'm sorry. So I will let her go ahead and get started with her presentation.
Thanks, Nicole. All right. So I do have a few questions embedded in the slide presentation. So make sure you have your cell phones out. So basically, I wanted to just talk about a few, they're basically guidelines, evidence-based guidelines that came out recently that I think sometimes we have a hard time keeping up. At least I know I do. So I thought I would review just not all the guidelines, because just to review one guideline will take probably 2 hours, but I just selected a few of the clinical pearls that I thought were practical, especially pharmacotherapy, since I'm a PharmD. And so the guidelines that I chose to discuss today are asthma. Does anyone know what the acronym is for the asthma guideline? Global Initiatives. Asthma, G-I-N-A, GINA. I think I heard you that way. So GINA. How about for COPD? GOLD. So GOLD guidelines, COPD, GINA guidelines, asthma. And so there's, and I know the last 2 times I've spoken here has been about diabetes, and I thought I'd change it a little bit, but there are several updates in diabetes that I thought I would point out as well. And then I'll review the new updates on pneumococcal vaccines and just a few points on neuropathy and heart failure. All right, let's test this QR code. Dr. K still has the flip phone, I think. All right, so it looks like it's working. And I think if you guys are joining us from virtually, you can also participate just using the QR code. All right, so the first topic is going to be on asthma. So global initiative for asthma, so GINA. And just a slide on some background information here. And the main point of this slide is to talk about how even patients that have mild asthma can have pretty significant consequences. So patients that have had mild asthma are still at high risk. And so this data shows us that 37% of adults with acute asthma, 60% of patients that had near fatal asthma, and 15 to 27% of adults that actually died of asthma. All of these patient populations, they all have symptoms less than weekly in the previous 3 months. So sometimes we think that, oh, just once a week in the last 3 months is not that big of an issue, but this data tells us that they can have acute exacerbations, near fatal experiences, and some people can actually die. Exacerbation triggers, as we probably know, viruses, pollen, pollution, and poor adherence. We'll talk about adherence in a little bit. And this, when I first read these guidelines, and this is not just from this year, but last year or the last guidelines, but I thought this was interesting that even 4 to 5 lifetime oral corticosteroid courses increase the risk of osteoporosis, diabetes, and cancer. So 4 to 5 times. So that's not very much. So I guess that tells me that we need to be prudent when we use these OCS for our patients. Okay, here's our first question. What is the PRN inhaler that you use in patients that have a newly diagnosed asthma condition? I don't know how many of you answered, but I saw 100% albuterol. Oh, one person. It could be just one person. Anybody else want to answer? No? All right. Well, thank you for those that are participating. So this is evidence for actually as needed ICS formoterol. So inhaled corticosteroid and formoterol combination in patients with mild asthma. So this is a meta-analysis of 4 trials. They were all randomized controlled trials. Nearly 10,000 patients participated, and 55% reduction in severe exacerbations compared with SABA. And SABA is a short-acting beta agonist. And I don't know why they call it SABA. It would be easier if they just call it albuterol. So 55% reduction in severe exacerbation when they compared the ICS formoterol as needed compared to the albuterol alone. When they compared it to the just inhaled corticosteroid plus albuterol, compared to the ICS formoterol as needed, there were similar risk of severe exacerbations. And it also affected the ED visits and hospitalizations. So when you use a PRN ICS formoterol, and that's Symbicort, 65% of patients had lower ER visits or hospitalizations compared to the albuterol alone, and 37% lower than with daily inhaled corticosteroids. So the main information here is that even PRN ICS formoterol is actually has shown to be more beneficial than albuterol alone or albuterol combined with inhaled steroids. And analysis by previous treatment. So patients taking SABA alone had lower risk of severe exacerbations with PRN ICS formoterol compared to daily ICS plus as needed SABA. So this information, I'm a very visual person, so I just kind of did this here. So ICS formoterol is Symbicort, so PRN. Use of this inhaler compared to PRN albuterol had a decrease in exacerbations by 55% and decrease 65% in ED visits. And then we talked about it being similar to PRN SABA plus daily ICS. And then the third one there is PRN ICS formoterol was better than daily inhaled corticosteroids. Again, decrease in 65% of ED visits. So that's a pretty significant change in data. Questions about that?
Not quite clear. I mean, a lot of times they get combined, right?
They get, the question was that, or the comment was that a lot of times they get combined. In,
So
I'm not sure I understand the question.
you're talking about one better than the other, so
So the PR, so the,
they get combined.
yes, eventually, yes. And so I'll show you here, this might be helpful here, this new asthma step therapy. So before, we used to use albuterol PRN. Now they're suggesting that the better alternative is ICS formoterol PRN first. PRN, SABA or albuterol is still an option, but the more evidence-based information is using the ICS formoterol as needed first. And then if you need to step up therapy, then you go to low dose, but every day instead of maintenance. I'm sorry, instead of PRN, you increase to low dose, but maintenance. And then if you need to step up another time, then you go to medium dose, ICS formoterol. And then finally you do the high dose ICS formoterol. So basically you use the same combination, PRN, low dose, but maintenance, medium dose maintenance, high dose maintenance. And then what if you have to add another inhaler, a third one? What would that be? So step 5, so you would add a LAMA if they still are not at goal with high dose ICS formoterol. So the LAMA is a long-acting muscarinic antagonist. What's an example? Ladies over here. Sorry? Spiriva, correct. So the epitropium, theotropium, the umeclidinium, so the IUM ending in that is a LAMA. It's a long-acting muscarinic antagonist. And then so again, the alternative is to use the albuterol, but the one with the best data is using the ICS formoterol and then stepping up. Questions about that? So this was this happened, I believe, about 2 or 3 years ago. And I know when I first started doing this, because I've been practicing for 20-something years, and we always use albuterol PRN. So moving over to this change was a little kind of unnerving, but the data is there, so now I don't feel as concerned. Yes, ma'am. So the question is, what about exercise-induced asthma? Well, so her question is whether they should, the people with integrated asthma and that exercise-induced exacerbation, whether they should still be using albuterol. And that's an excellent question. I actually do not know the answer. I didn't look into that population. All right. So the question is, what is the cost of the ICS formoterol versus the albuterol? And you know, I think the answer is it depends right on the insurance. But if you just go to RX and just pay cash, I believe it's about maybe $300. Interestingly, though, I didn't know this until I was preparing for this presentation. There's actually a generic version of ICS formoterol that's available. I don't know how much that costs. And it also depends on the system that you work in. I know in our system, in the university health system, we get a discount. So it's usually less than in other pharmacies. Other questions? All right, so just other helpful points in terms of PRN, budesonide formoterol, which is the ICS formoterol. It's a single activation of 160/4.5. And what they say when they were using it as needed, well, they suggest that you can go up to 12 inhalations per week, but they said the average dose was about 3 or 4 doses as needed. And the question also that comes up is, well, can I use other ICS formoterol formulations? And they're suggesting that other formulations have not been studied, but the beclomethasone formoterol may also be suitable, is what they suggested. And this is something else that I also learned, because as a pharmacist, I'm always educating patients, make sure you rinse your valve after you use your inhaled steroid. But apparently when they use a PRN, that's not necessary. And basically they say it's not because they didn't require it in the studies. So, all right, so this is one of the, let's see. I think my slides got. Are you guys? Yeah, so this is one of the generic versions of the budesonide formoterol. Just wanted to share with you, this one was approved last March. And apparently there's another generic that was, I guess, authorized generic, which means that the company sold the rights for Symbicort to be used generically. All right, I'm going to move now to the gold guidelines with COPD. This was updated just this year, 2023. And so before, I don't have a slide or question, but if you have a patient that you have newly diagnosed with COPD, besides maybe albuterol PRN, what is the first inhaler that you would use as your therapy? If you have a COPD patient. Any thoughts? Albuterol, yes, so besides albuterol, what would be the next one? Combinant. Okay. And you suggested something else? Anyone else? So usually I would use Spiriva before these guidelines came about. But now they actually suggest something different. So they used to have 4 groups for COPD, A, B, C, and D, and now they kind of merge them and combine them. So basically for patients group A, the more mild patients, this suggests you can use a bronchodilator. But if you have to step up to the patients in group B, then the combination of both a LABA, which is a long-acting beta agonist, plus a LAMA, the long-acting muscarinic antagonist, like Spiriva, tiotropium, umeclidinium. So the combination. Okay. So for asthma, because it's an inflammatory condition, right? So inhaled steroids plus the LABA. For COPD, it's the LABA plus the LAMA, which is a long-acting antimuscarinic. So that was new. So this is new for me as well in terms of practicing. I'm sorry? Oh, yes, yes. They have, so he's talking about another combination. Yes, correct. And I'll show you a list of these combinations as well in just a minute. And this comes from the guidelines. I just wanted to share with you here. This is evidence A, which is clear evidence. I just circled the one in red. So combination formoterol, salmeterol, and the LAMA, again, like tiotropium, increases the FEV1 and reduces symptoms compared to monotherapy. And then the next point there is combination treatment with LABA plus LAMA reduces exacerbations compared to monotherapy. So evidence A for the first bullet and evidence B. So they're both pretty good in terms of the data to back these guidelines up. And this is a chart that I have on my door that I would recommend that you get. It's from the Allergy and Asthma Network. In fact, I just ordered some for our clinic and for our residents. They're not too expensive, but it has on the top is the short-acting beta agonist, like the albuterol, and then the other section is long-acting beta agonist. So short-acting, long-acting. The orange brownish portion there, it has the inhaled corticosteroids alone. The muscarinic antagonist is the kind of yellow-orange part. So that's where you have the adjuvant, and you can see the adjuvant is the only short-acting LAMA. Then the other ones are the inclusive, the Spiriva there, that's your tiotropium. Then the Respimat, the Tudorsa. Tudorsa is one that is actually breath activating. And then the kind of greenish gray down at the bottom, these are combination medications. And for these purposes, I just kind of put out the LABA-LAMA combinations. So out of the first of the Ellipta, which one is the LABA? The umeclidinium or the vilanterol? The LABA, long-acting beta agonist. So the vilanterol is the LABA. And the Bevespi, the glycopyrrolate is the LAMA, the long-acting muscarinic antagonist. It's got formoterol in it. The Duac, I actually have never used this one. Duaclear, press there. So that one has aclidinium, which is the LAMA, and also has formoterol. So formoterol again is a long-acting beta agonist, and then Stilto has tiotropium and olodaterol. So these are the ones, the combinations that you could use for your COPD patient. And how do you guys practice in your clinics or in your setting? If you have a patient with a new inhaler and they don't know how to use it, who does the teaching? You do? Okay. And how do you teach? So I don't know all these inhalers and how to use them, so I'd have to look it up. What do you guys do? Who has that? Or website you saw? Good. Okay, so she's talking about how that, if you go to the manufacturer website, it has a detailed video on how to use that, and that's correct. So if you just type in the brand name.com of any medication, it takes you to the package insert. And nowadays, she's right, they all have videos of the device. This website I'm going to share with you is it's one that I've shared for a few years and it's still active. It's called use-inhalers.com. So if you have medical students or MAs, you can, and you have a computer in your clinic room, you can actually pull that up. And I'm going to show you here really quick. So it looks like this, and it's available in several languages. And Dr. K, for you, we're going to choose, oh, it's not showing? Oh, bummer. Oh, right. Maybe do I need to change? We played it earlier and it worked, just you know, we will keep playing. That's okay, I think, as long as we have that website and use-inhalers.com, that's the most important thing, but there's two questions that are questions. Oh, yes, sir. Absolutely. Yes. All right, so we couldn't get the video to show, but this website has just asking you two questions. First is that what language do you want? So of course, I always use English. Now we do have Spanish, and they have other languages as well. You choose your language, and then it has a picture, not exactly like the one I just showed you, but a picture of each of the inhalers. So you click on that one, and then it has a video of the Spiriva, the inhaler, the Respimat, whichever inhaler you choose, and then it's going to show you how to do that. So again, if you have MAs or medical students or assistants, you can just have them put that on for the patient, and then you can come afterwards and see if they have any questions. So to answer your question, so this question is, can you comment on the efficacy of nebulized albuterol, for example, compared to the MDI, the meter dose inhaler? And what I know about that is that they are equivalent if you use them correctly. And I actually have a statement here. Look like. This is kind of a an example of one. And basically, you're gonna connect the two together, and then they inhale it. So if they do it correctly, it's actually equivalent to a nebulized inhalation or nebulized treatment. But I think it was 4 to 8 puffs using a spacer and doing the correct technique is equivalent to the nebulizer. You know, what they say though is that because the patients that are having an asthma exacerbation, they're stressed, they're breathing hard, so they really can't manipulate the inhaler and the spacer appropriately. So that's why they use the nebulizer in these patients. And so again, because I'm a visual learner, this is just kind of a summary of asthma versus COPD. So they both use the LABA long-acting beta agonist. But if you have an asthma patient, you're going to start with the ICS, inhaled steroid plus LABA. And you go again, PRN, low dose, medium dose, high dose. And if you need to add another inhaler, it would be the LAMA, the long-acting muscarinic antagonist, like tiotropium, for example, or umeclidinium. For COPD, you start the opposite. You start with the LABA plus the LAMA. And eventually, if you need to add another agent, you can add the inhaled corticosteroid. Questions on these slides? So those are just my practical take-home messages on these two that I thought you guys would appreciate. So next, I looked at the 2023 standards of care in diabetes. And again, I only selected a few things because, all these guidelines are very long. This is the evidence grading system. So A means it's very clear evidence. And it goes all the way down to B, C, and E. E is expert consensus or clinical experience. That just makes sense. And this is the one that sometimes changes depending on the year, really. So every time that the ADA guidelines come out, I look at this section because I think it's something that we don't really pay attention to much, which is prevention of diabetes or delaying diabetes. And so the age group that they suggest using metformin, again, changes, but now they've been consistent recently. So their suggestion is to consider metformin for prevention in adults at high risk of type 2 diabetes. And these are the groups. And this is, by the way, level evidence A, which means it's clear evidence. Do you have a question? Oh. So patients that are between the ages of 25 and 59, and they have a BMI of greater than or equal to 35. Another group is those that have a higher fasting plasma glucose, more than 110, or an A1C greater than 6. Remember that pre-diabetes is 5.7 to 6.4. So if they have an A1C between 6 and 6.4, then maybe they should be on metformin. In individuals that had prior gestational diabetes, they also suggest that these patients should also be treated with metformin to prevent the development of diabetes. Questions on it? When I mentioned this to the resident as we're discussing diabetes, they're always very surprised about this. And they're surprised because they don't do that. And so, this is something that we have to keep on reminding ourselves, and really prevention and delay is really the best thing to do is weight loss, exercise, right? But we know how not easy that is, how difficult that is. And so metformin is also recommended. And there's a question, yes, ma'am. The GLP-1. So the question is, how is this, I guess to comment on the use of GLP-1 instead. So if they do talk about weight loss and using drugs for weight loss, but in terms of the prevention and using metformin, these are the groups that they talk about. But they do suggest that we do need to encourage our patients to lose weight. And then if we need to use medications, that we use them, in fact, add Mounjaro to the list of different medications. Okay. And the other thing that you have to consider, because there's also, they've studied other drugs as well, like pioglitazone. So that's also been shown to delay diabetes in some populations. But you have to consider the safety, the effectiveness, and also the cost of the medication. So while the GLP-1s are probably safe and effective, they're not very affordable in some cases, in many cases. And then I would like to remind us that metformin can be associated with vitamin B12 deficiency. And so make sure that you look at that. There's different camps. You can look at that initially and then check periodically and then treat when it goes down. Or I'd say, B12 is a very water soluble and safe vitamin. I'd say let's just do it ahead of time. But you could choose whatever camp you feel more comfortable with. All right, so this one, I like to share this because I think we don't pay attention to this as much in terms of hypoglycemia. We know we get it and it happens, and but for patients that are really at increased risk of hypoglycemia, we don't really use glucagon. So maybe you tell me, raise your hand if you've used glucagon in the last 3 months for your patients. Prescribed, not sorry, yeah, prescribed. Okay, so a handful, actually 2 are out of the group here. Good. But I don't think we do it enough. And caregivers, school personnel, or family members providing support to these individuals should know where it is and when and how to administer it. Glucagon administration, they suggest, is not limited to healthcare professionals. So I think we need to be using it more. And I've always had this idea of looking at our ER visits due to hypoglycemia. And I suspect that there would be a lot that we could prevent. And in fact, I brought some samples of glucagon, not glucagon, glucose tablets. So I actually have tubes in my office that I actually give out to my patients. So I think that every patient that has a prescription for insulin should also get a prescription or a roll of glucose tablets with education on how to use it. Questions on that? All right, so if you have your cell phone, see what you think about this. So according to the recent ADA guidelines, what is the BP goal for patients with diabetes? What is the most recent blood pressure goal? Less than 120/80, less than 130/80, less than 135/85, or less than 140/90. Anyone else? All right, so we have a mixture of answers. And I'll tell you what the answer is, but answer this question first. If you have to use a 4th option for blood pressure control, what agent would that be? This is after ACE inhibitors or ARB, thiazide, calcium channel block. What agent would you use? What's the blood pressure goal and what agent would you use as your 4th agent? Assuming no contraindication. All right, so this is the 2023 ADA guideline for hypertension. They suggest that the goal should be less than 130/80. So some of you guys got that right. So once it's 130/80 or above, then they qualify for drug treatment. And then this is a quote: individuals with hypertension who are not meeting blood pressure targets on 3 classes of antihypertensives, again, the ACE/ARB, never those 2 together, the calcium channel blockers or thiazide diuretics, and they're taking the medications, adherence is key, right? Then the 4th agent they suggest should be consider a mineralocorticoid receptor antagonist. So, and in terms of which drug to start, there's really not that much of, that's going to depend on your patient, right? So if they have potassium that's really low, less than 4 really is the general recommendation. They probably should not be on the thiazide diuretic. But in terms of the first drug, the only time they suggest it should be an ACE or an ARB is if they have microalbuminuria or CKD. It should be an ACE or ARB. And then after you do 3 drugs, if you need a 4th one, then a spironolactone or a clarinone for that matter. What is your 5th agent if you need a 5th one? I have had to go to my 5th agent. What do you guys do? Hopefully before the heart attack. So I usually use the beta blocker and carvedilol. Before, when I learned JNC5, this is the JNC8 and beyond. For JNC5 and back then it was diuretics and beta blockers are the top line agents, but now beta blockers are at the end. So this is just a slide that's adding the spironolactone and eplerenone as the fourth agent. And I have a pharmacotherapy clinic, and a lot of times I get patients with resistant hypertension, and invariably they've never been on spironolactone. I put them on it and they nicely get under control. In addition to adherence, of course. All right, they also have some changes in lipid guidelines in patients with diabetes. So this is, something that comes up often, right, in patients older than 75 years old. They're saying that if they're on a statin, they say continue statin therapy in adults with diabetes that are age greater than 75 years old and getting a statin currently. So if they're on it, continue it. And the second point is, if they're not on it, it may be reasonable to initiate moderate intensity statin in adults with diabetes age greater than 75 years. And up until recently, I think these patients that were older than 75, we questioned about whether we should take them off, minimize the medications. This year, they're suggesting that we can continue it and or we can start it. Questions on that? All right, and then this is the other big change, I think, which is the LDL goal. So for primary prevention, we're suggesting the LDL goal of less than 70. For secondary prevention, for patients at higher risk, LDL less than 55 is the goal. And for primary prevention, they say, well, the general recommendation is to reduce the LDL by 50% from the baseline. But I know in our clinic, if I see a patient, then several of you have seen the patient and they've had several labs since then, we don't really know what was the baseline. Sometimes it's kind of hard to find out what is the baseline and then what's 50% from that baseline. So they're suggesting, because that's not very practical, it's not very easy to determine. Let's just say the goal is less than 70, primary prevention. Secondary prevention, LDL less than 55, which is going to be harder to achieve. And so that's why they suggest that if you need to, use the ezetimibe or the PCSK9 inhibitors to achieve that goal. All right, questions on this? Yes, ma'am. Yes. Right, so so the question is, do the PCSK9 inhibitors have the data for outcomes as opposed to just the markers of decreasing the LDL? And I can't say conclusively that I know the answer. They do decrease it, but in terms of outcomes without a statin, I'm not quite sure. Most of the time they're in addition to a statin. I know there's been maybe one patient that I can remember that had really severe allergy to the statins, and they were on a PCSK9 inhibitor, but that's another good question, and I don't know the answer. Okay, so I'm sorry? Okay, yes, so the question is about the PCSK9 inhibitors and the outcomes, and I'm not very familiar with that. I have a couple of patients on it, but I don't know. Right, so the comment is that she wasn't aware of the LDL goal of less than 55, and to your defense, this is new. Not quite hot off the press because the ADA publishes these online every December. So by December 2023, the guidelines for 2024 are available. So sometimes it's kind of trying to catch up with the last guidelines and the new ones already come up. But I thought these were things that are going to change our practice. So I shared this. And so the other thing, I don't know that it's, maybe you already know this, but I don't have a slide, but in terms of how to start treating a patient with diabetes. And I believe the last guidelines also have it, but it's probably worth mentioning that before we all agreed on that the first drug of choice for patients with diabetes should be metformin. And for the most part, I think that's still there. But if you have a patient that has CKD or they have heart disease, then those patients should actually be started on either SGLT2 inhibitor or a GLP-1 receptor agonist. Okay, this is independent of the metformin. Most of the time, though, they probably can use the help of the metformin. So most of the time, I start them on the combination of Farxiga and metformin, the Zigduo or the Synjardy or the Invokimab. So, and if they need weight loss, then the GLP-1 receptor and agonists are helpful. All right. Anything else on diabetes? Again, this is just just a small few points that I pulled from the guidelines that I thought would change our practice. And so I'll move on then to the pneumococcal vaccine update. These are CDC recommendations. And these are the vaccines that are available. So the previous vaccines we had were the PCV13, and which is a Prevnar 13, and the PPSV23, the Pneumovax. Now the new vaccines are the PCV15, which is the Vaxneuvance, and the PCV20, the Prevnar 20. And I have these websites here, which is where I got most of this information from. They're both CDC websites. So I have a couple of slides to answer that question, which is about when to use which vaccine. I just have this one slide on children 0 to 18 years. No changes yet, as far as I know, to the ACIP recommendation. From 0 to 2, they still recommend the PCV13 series. And for the 2 to 18 with medical conditions, also the 13 plus and 23. So no changes there. And just a couple of notes there that the PCV15 has been approved for ages 6 weeks to 17 years. Prevnar 20 is not yet approved for this age group. And so for now, we're going to continue to follow the ACIP guidelines for this young population. And maybe to answer your question, this is, I thought these were nice charts to kind of look at. Okay, so what do I do from this point on? So this is for adults 19 to 64 that have immunocompromising conditions. So if they're not, they don't have any vaccines in their background, then option A is just do the PCV20. And then we're done there. The patients that had 23 only, then if it's been a year since the last time they received it, then you can do the PCV20, or option B is you can do the PCV15 for those patients. If they've only had the PCV13, that's kind of the third one down, then you can use the PCV20, or option B is do the 23, and then after 5 years, the 23 again. If they had, now the fourth one, if they had 13 and 1 dose of the 23, again, option 1 is you can use the 20. So you can use the 20 for all these patients, but they do have some options. I know like in our clinic, we don't have a PCV20. So some patients actually have to go to the pharmacy to get that. But they do have option B there as an alternative. And then, so at the bottom there, they have the immunocompromising conditions, which is different than another. So this one doesn't have diabetes, but the other table that that I have here does have diabetes and a few other immunocompromising conditions. So, but this other slide here has the vaccine updates for patients that are 65 years of age and older. So again, for the most part, you can just, whether they had the PCV23 or the 13, you can use a 20 for most of those patients. That's option A, but they do have an option B depending on which one they already had before. Did that answer your question? Okay. Why do they make so many? I don't know the answer to that question either. So the question is, have I used the app? And I have not. I use this information.
They also keep time for 6 o'clock. Because, you know, it's at the time that.
Good. Dr. Nate is suggesting to use the app because it also helps with the time frame. Good. And another comment from you? The question is, why is it so difficult to get the PCV 20? And I'm sorry, I don't know the end. And then the other barrier is that, what insurance plan do they have, right? Some insurance plans cover it for it to be, injected in the clinic. Some of them have to, have a requirement to go get it at the pharmacy. So that's the other issue as well. Okay, yes, so Dr. Moribel is saying that's a bigger issue. Let's see. An additional note for the vaccine. So the PCV 15 is now replacing the PCV 13 in adults, but not in children. Complete any PCV 13 series with a 20 PPSV 23. If the PPSV 23 is not available, then the PCV 20 for one dose only, and then we're done. And then another point here that the PCV 15 and the PCV 20 are never indicated in a series together. And then spacing between the doses. So 1 year between PCV and PPSV 23, and 5 year spacing between the 23 booster doses. All right, so that's all I have on the pneumovax. And, you know, I found this guideline on painful diabetic neuropathy, and I don't have a whole lot of points, but I wanted to share something that I thought was interesting that I learned that we should focus on. And it's basically the first one, which is assess patient with diabetes and painful diabetic neuropathy for concurrent mood and sleep disorders, because they suggest that. I think we do that for the most part for most of our patients, but they're suggesting this is really important when they have pain to address the mood and sleep disorders. Do not use opioids for treating painful diabetic neuropathy. And in terms of the medications, I don't think that's changed. So TCAs, SNRIs, gabapentins, and or sodium channel blockers to reduce the pain. And one thing that they emphasize is to make sure our patients know that it's not going to get rid of the pain, but the idea is to at least make it more comfortable. So for patients who achieve partial improvement with an initial therapeutic class, offer a medication from a different class or combination therapy. I think that kind of makes sense. But I thought the most probably useful was this table here that has the medications and the dosage and the duration. Okay, so I know we use like gabapentin and Lyrica in our clinic a lot. And like the gabapentin, for example, the pregabalin, if you look at the dose, is 300 to 600, which is actually pretty high. And I think at that point, you start seeing pretty significant side effects as well. So I think it's always, I think what we usually practice, which is start at a dose and then increase as tolerated and as helpful for the pain. And Dr. Nader, you have a question? Yes, kidney function. Absolutely. So he's reminding us to check kidney function for these patients. So that was for neuropathy. And then just a few points on heart failure. This is from Circulation May 2022. And these are some updated guidelines that I learned something from as well. And the first one is that now we have not just one classification, but now we have several heart failure classifications. So we have the HFrEF, which is LVF less than 40%. And then we have, I don't even know how you say this, HFiMPEC, maybe. And so this is a previous LVF of less than 40 and follow-up measurement of LVEF of more than 40%. And then the other classification is HEMREF. This is LVF between 41 and 49%. Have you guys heard of all these classifications? No? Two of them. All right, so we're learning some, we're learning together. These are not words. That's right. And then the other one, so I just knew about the HFrEF and the HFpEF. You said two, maybe. The other one I didn't know. So the other one is the HFpEF, the LVF more than 50%. All right, so I have a Slido question here. Which of the following is recommended as first line to reduce morbidity and mortality in HFrEF, the reduced ejection fraction? So an ARNI, an ACE inhibitor, ARB, or an SGLT2 inhibitor. Got it? All right. So this is from the guidelines here. So one of the first things they say is that the GDMT, so the medication therapy has now expanded to 4 classes. So the ARNI, the ACE, well, I'm sorry, the renin-angiotensin system inhibition is 1, 2 beta blockers, 3 mineralocorticoid receptor antagonists, and 4 now they include the SGLT2 inhibitors. Okay. So the answer to the question is in the box there in blue. So ARNI is recommended as first line to reduce morbidity and mortality in HFrEF patients. This is class of recommendation 1A, which is pretty clear evidence. And then this is the other thing that I learned, that in symptomatic patients with HFrEF who tolerate ACE inhibitors or an ARB, that if they're symptomatic, then replacement with an ARNI is recommended for further reduction in morbidity and mortality. So ARNI is the winner here. And do not give ARNI within 36 hours of the last dose of ACE inhibitors. I know, and in the ARNI, the Entresto, it has to be dosed twice a day. I know I have one patient that she has some dementia. She lives with her husband, but he's not very helpful in reminding her. And so she forgets her twice a day Entresto. She can only take one because her providers are in the morning, but the second dose is really hard for her to remember. So I think in that patient, perhaps we decided to just do the once a day ACE inhibitors for her, I believe. So, so right now it's a twice a day medication. So that's the only downfall, but it does improve morbidity and mortality. Yep. Anything else? I believe that is all I had for today. Thank you.
Okay, thank you. Great. So we're going to be moving on the items in our agenda. So we don't have any report for officers right now, but we go to 26, we've been recent. So we have the nomination and election of the 2024 officers. So just to explain to you, so we have the nominee for president is Dr. Michelle Avery, and the nominee for president is Dr. Moni Bailey. Those two positions are not to vote, but they will be elected tonight. And we have 3 positions, which we have nominee for 2. For vice president, we have Dr. Oralia. We have the treasurer, Dr. Mary Quinn. And we have a open position for secretary. So to this point, we're going to take any nominations from the floor for either of the 3 positions, except for the secretary, that we don't have any nominations so far. So if anyone wants to be a nominee for any of the positions. When I give you a couple of minutes to okay. So what we have to talk about this is we get to elect after the vote the nominees we have, and we will fill the position of secretary when we have a person that is needed. So okay, so let's say the vote. So vice president will be Dr. Laura Hensfield, treasurer Dr. Mary Wynn. So I think any motion to approve? Okay. Second, anyone opposed? Okay. So the official we have elected For 2023-2024, Dr. Michelle Avery for president, Dr. Cody Motivated for president-elect, Dr. Laura Nickfield for vice president, and Dr. Mary Winston. It will be solved in March. Okay, okay. Anyone have any questions before we move to, the last two items? Okay. So for item 7, we have an answer, so we had a meeting with, the TAFP leaders from all the countries. That's why that we have. So,